hello everybody, and welcome to the Ask the Expert session. So as Soraya mentioned, I'm Lizzy Rodgers. I'm Deputy Director of Services at Target Ovarian Cancer, and I'm really thrilled to welcome an amazing panel of local clinicians today to answer your questions as part of this question and answer session. So we have three amazing experts with us today. So I'm going to ask the panel to introduce themselves now, starting with Aarti. Aarti, are you here?
I am here. Hello.
Hello.
Can you hear me?
Yes, I can. So would you just like to tell us who you are, Aarti, and what you do?
So I'm Aarti Sharma. I'm a consultant at the Heath Hospital. I'm one of the surgical consultants. So I'm a gynae oncology surgeon. So that's what I have been doing for the last 8.5 years. And before I joined the team here in Cardiff, I had done my specialist training in Nottingham and had done 3 years of research with the UKC tox trial, which many women would know about in London. So that's my background. And thank you for inviting me. It's a great pleasure to be part of the panel.
Thank you, Aarti. And now, Sarah, could I ask you to introduce yourself?
Yeah, hi, I'm Sarah Burton. I'm a Macmillan gynae oncology specialist nurse working at Velindre Cancer Centre. I've actually been a specialist nurse in gynae oncology for the last 27 years now. So thank you for asking me to take part in the panel discussion. Thank you.
Thanks, Sarah. And Emma, could you introduce yourself? Oh, we can't hear you, I'm afraid.
Sorry, we thought we'd be used to that by now, wouldn't we? Sorry, everybody. So my name's Emma Hudson. I'm one of the oncologists at Velindre Cancer Centre. I've worked in Velindre for 17 years now. So now I just treat gynaecological cancers, actually, having previously treated some others as well. I'm chair of the NCRI. I'm on the executive board for the NCRI gynaecological groups. So we're quite active in clinical trials and try to bring as many trials to Wales as we can. And as the others said, thank you very much for inviting me. I'm delighted to be here as well.
Thank you, Emma. So I think we're going to jump straight in. So talking about treatments, so chemo and maintenance therapy for ovarian cancer. So we've had a lot of questions and particularly focused around new treatments, but I was wondering if it might be useful to start with a quick explanation of what the standard treatment is for ovarian cancer, and then we can start talking about new ones. So Emma, could you kick us off by just a very basic explanation of what the standard treatment that might be expected?
So obviously the standard treatment is very much dependent on what type of cancer we're dealing with. We've heard already today that, you know, there are different types of cancer such as clear cell and other types of ovarian cancer. So it depends on the type and it also depends on the stage of the disease. But primarily what we're trying to do is remove all of the disease. And if that can be done up front, then the first part of the patient's treatment is usually surgery. If that's not feasible initially, and that can be for a variety of different reasons, either related to where the disease is or related to the person or for other different factors. Sometimes we give what's called neoadjuvant chemotherapy. So that's chemotherapy where we aim to shrink the cancer down prior to the operation. We always follow up or always try to follow up the surgery with further chemotherapy. And that was the standard treatment for a very long time. In more recent years, as I'm sure most of you are aware, we're now using what's called maintenance treatment. So after the chemotherapy, so after the surgery and then the chemotherapy, we now sometimes give maintenance treatment for some patients. And that's to either reduce the chance of the cancer coming back again or defer the cancer coming back again.
Great, thank you, Emma. So let's go into the first question. So somebody's asked us what new treatments are available for stage 3 and above.
So back 10 years ago, there wasn't, the only treatments were chemotherapy and surgery. And then about 6 or 7 years ago, bevacizumab, or Avastin as it's more commonly known, became available for stage 3 disease if the surgeon hadn't been able to remove the cancer in its entirety, or stage 4 disease. So that was used then as a treatment with chemotherapy, but also after chemotherapy as a maintenance treatment. So that was bevacizumab. So we had surgery and chemotherapy, and then we had surgery, chemotherapy, and bevacizumab for stage 3 disease. Last year, for people who've got a BRCA mutation, so that's a mutation, a genetic mutation that can either happen in somebody's germline, so in all cells of the body, or specifically actually in the tumour. So if people have got a BRCA mutation, last year those people were able to have a drug called a PARP inhibitor called olaparib after the chemotherapy, but that was restricted initially to that cohort of patients with the BRCA mutation. And then just towards the end of last year, another different type of PARP inhibitor called niraparib was licensed for use in all comers actually. So for anybody with stage 3 or stage 4 disease could then have treatment with a PARP inhibitor. So as I said, 10 years ago, there wasn't anything. Then we had bevacizumab, then we had olaparib. Both of those were for specific cohorts of people with stage 3 disease. But now we have this other drug called niraparib, which is actually for all comers with stage 3 disease, if they can tolerate it. Obviously, there's certain individual circumstances which might mean that that's not appropriate for somebody. But as a general rule, that is certainly to be considered. And in addition to that, for those patients who've got a BRCA mutation, now they can potentially, in some situations, they can be candidates for the PARP inhibitor olaparib in addition to the bevacizumab. So that is in a different situation, but that is an option for some people. So we've gone from not having anything apart from chemotherapy in not too long ago to having all these different systemic options. When I say systemic, I mean that means drugs really, so treated with different medications. So there's a lot of different options now available. Thanks,
Emma. So that leads us quite nicely into the next question that we received. So this one's particularly about the drug niraparib. So somebody's asked, I've been taking niraparib for 2 years. Have more side effects been found with longer use? And they specifically asked about muscle weakness of the legs, whether this could be due to PARP inhibitors.
So we've been using PARP inhibitors for the last sort of, well, initially in trials and now outside of trials, but we've been using them for quite a few years now. We know, conversely to that question, we know that the first month or so using a PARP inhibitors, the side effects tend to be worse. So during that first month, people often do experience quite a lot of nausea, or they can do quite a lot of fatigue, and those symptoms actually settle with time. And there's quite a good sort of reported outcomes from different people who've had that experience. If we can get people through that first month or so, then actually the toxicities are much better tolerated. The number of people that we've got having taken a PARP inhibitor there's people in the original trials who are still taking them 5 years plus on. So we have got, some people on them, but that number of patients isn't huge. We do know that toxicities from all drugs can be accumulative. So it's the same actually with bevacizumab, although it's not particularly detailed. When people have been on it for some time, they do actually also get aches and pains in the muscles and joints. And it can be the same for the PARP inhibitors. There isn't much detailed analysis of that, as I say, because that cohort of patients who've been on them for that length of time outside of a clinical trial obviously is not huge at the moment, but it is there, yes.
Okay, thank you. So let's move on beyond PARP inhibitors, and we've been asked about various different kind of newer treatments that people have heard about and whether they are relevant to ovarian cancer. So the next question's about immunotherapy, and Emma, it might be great if you could just basically explain what that is. And then the specific question is, are there any trials in Wales with immunotherapy?
So immunotherapy is a different type of treatment. That's a treatment whereby medicine is given to try and stimulate the person's own immune system to attack the cancer itself. So that's how it works. So it works in a completely different way to chemotherapy or the PARP inhibitors or any other treatment. Now, immunotherapy has completely transformed the treatment of some cancers, particularly skin cancers such as melanoma, and it's been used in lung cancer and a lot of others. Now, for reasons that we don't really understand, to be honest with you, the earlier immunotherapy trials in ovarian cancer were negative. So that means that the immunotherapy didn't have the response that we expected it to have. More trials are being done to see if there is a role for immunotherapy, because scientifically there should be. So we don't really understand why these trials have been negative. There have been some big first line, when I mean first line, I mean trials after that initial surgery, so the first treatment that somebody gets. There has been some first line trials in immunotherapy. We haven't got any of those open at the moment locally. Most of them have now shut, actually. They've completed and we're waiting for them to report. There is a trial later on, so in people who've had surgery and who've had chemotherapy, and further down that pathway, there is a trial in the pipeline looking at immunotherapy with bevacizumab and chemotherapy. Now that's in quite early stages, but hopefully that, we're June now, aren't we? So hopefully that might open towards the end of the year or perhaps early next year, but we're hoping towards the end of this year. So although there aren't any at the moment, they're coming, and there will be this one particularly in the not too distant future.
Lovely. And just coming on to the last one in this area. So we received a couple of questions actually. So one about attacking cancer stem cells, and another about whether CAR T-cell therapy works for high-grade serous ovarian cancer. So it sounds to me like people are wondering if any of these kind of newer treatments being used in other cancers would have benefit in ovarian cancer. Is there any evidence out there that you know of, Emma, that these might be coming down the line for people with ovarian cancer?
Not at the moment. So there hasn't been any use of either CAR T or stem cells in ovarian cancer in clinical trials at the moment. So no, there isn't any evidence for it at the moment at all.
Great, thank you. So we're going to move on now. We had a few questions about monitoring during and after treatment. So the first question about this is, how often should I expect a scan? And Sarah, I think, is going to take this one.
So all ladies will have had a scan in order to make their initial diagnosis. If they go on and have surgery followed by chemotherapy, we would look, certainly within the cancer centre, to do a sort of a mid-treatment scan after about 3 cycles of chemo. Certainly if the patient in particular hadn't have had surgery, if they were what we call neoadjuvant, we would be looking to do that scan to see, number one, if the chemotherapy had actually helped to shrink the tumour, and also if the surgeons who had previously reviewed the patient thought that maybe they would possibly be suitable for interval debulking surgery. So that interim scan would be really important for that. If, however, they'd had surgery up front with a good outcome, and we were just given what we call adjuvant chemotherapy, we wouldn't scan until they'd completed their 6 cycles of chemo. With the ladies who were having neoadjuvant chemo, we do the scan after 3 cycles, as I said, but then we would also do another scan at the end of the chemotherapy. So if they did go for surgery interim after 3, we would carry on with another 3 cycles of chemo and then scan at the end. Once we then began the follow-up pathway, we would only scan if the CA125 was rising over a period of time, or if they were symptomatic. But obviously a lot of our ladies now are accessing the PARP inhibitors sort of as first-line maintenance. So there would be no set sort of scanning times, and ladies sometimes find that a little bit difficult to understand. You know, lots of our patients will say, well, do you not scan me every 3 months? but we don't scan every 3 months because there is obviously exposure to the radiation by doing that. And we would need a clinical reason for scanning because of that. So either they were becoming symptomatic, or if their marker was following a trend and starting to rise. So hopefully that makes sense.
Yes, it's very clear. Thank you, Sarah. And again, this brings us on very nicely to the next question. So somebody asked us, why are CA125 tests not routine? And people might be aware that CA125 can be used to monitor you after your treatment, but it can also be used before diagnosis to give an indication that there might be a need for further exploration. And it's not clear from the person who asked this question if they're interested in pre-diagnosis or post-diagnosis CA125. I feel like I'm making this very complicated, apologies. But Aarti is going to talk about the use of CA125 before diagnosis, and then Sarah's going to cover post-diagnosis. So Aarti, could you just explain to us why CA125 tests aren't routine and aren't used for screening?
Okay, CA125, as we know, is a tumor marker, and we've all heard about CA125 in both the contexts, as you mentioned, Lizzy. So pre-diagnosis, it's actually quite non-specific marker. So though we say that if it's raised, we should worry about ovarian cancer, but unfortunately it can be raised in other things as well. So if a woman is premenopausal, so she's not been through the change, the CA125 blood test can be raised in many other conditions unrelated to gynecological conditions. So in gynecological conditions other than ovarian cancer, it can actually be raised even during when a woman is going through her period. It can be raised in a woman who's got fibroids. It can be raised in conditions which are not gynecological, like lung diseases or anything else that irritates the peritoneum or inner lining of the abdomen. So any of that can actually cause a raise in the CA125. So if we did CA125 randomly on people, then this could be raised and cause a lot of concern. So it's not something that we routinely offer as a yearly check for women because it's not, it's just not specific enough. And worse so in premenopausal women because it can be raised due to so many other things that it can cause quite a bit of anxiety. But CA125 is one of the oldest tumor markers that we know for ovarian cancer. So it is used, but it's got its place. And certainly, I'm sure Sarah will inform us more about this for afterwards. But prior to diagnosis, using that as the only diagnostic factor doesn't work. UKC Tox, which was the largest ovarian cancer screening trial in the world, actually, and recruited over 200,000 women in the UK, has recently reported, and they have actually used CA125 as one of the screening tools. So when they were screening in the trial, they divided the 200,000 women basically into 3 groups, 100,000 as control, 50,000 CA125 monitoring, and 50,000 with ultrasound screening. So they had a pelvic ultrasound. And they had some very specific protocols to run the CA125, which was not related to just the CA125 blood test as a number on its own. They used it with an algorithm which included the woman's age and what previous results of CA125 they've had. So it was a complex algorithm, but when they initially reported after a 6 to 7 year follow-up, there was some indication that maybe monitoring the CA125 on a yearly basis may have some benefit over ultrasound scan. So that was the initial thought, but they carried on. And more recently, they've reported on the, between 15 to 16 year follow-up of these women. And unfortunately, it doesn't show that screening with CA125 is actually going to be of any benefit. And that is where the difficulty lies. So one, it's not specific. And one of the largest trials in the world has actually shown that routinely monitoring with or routinely trying to screen with CA125 is not going to pick up ovarian cancer, unfortunately.
Thank you, Aarti. So now we'll move to talking about using CA125 after diagnosis. So Sarah, could you just explain to us how it can be used to monitor people with ovarian cancer and when people might expect to be CA125 tested?
Okay. So the majority of women diagnosed with ovarian cancer will be what we call CA125 secretors. So the majority, so of 80 to 90%, but not all. So providing that their CA125 was raised upon diagnosis, that would then confirm to us that they are a secretor. We would look to use that to help us gauge when they're having their chemotherapy. So we'll have the CA125 at the start. Let's just say it's 500. So if they're neoadjuvant, might be a lot higher, might be a lot less, but as long as it's over 35, we know it is sensitive. We would then look to check the CA125 every 3 weeks prior to each cycle of chemotherapy, but we don't use it, certainly as Aarti said, is by no means reliant enough as a standalone. It can help us gauge whether they're responding or not to the chemotherapy, and if they were, we would hope to see that CA125 start to come down, and we would interpret that as being a biochemical response. But also, more importantly, we would be asking the patient clinically, how does she feel? Because very often starting chemotherapy, if they've not had surgery, they've got the tumour bulk on board, so that tumour will be giving them some symptoms, and we would hopefully be monitoring the patient clinically, seeing that maybe if they had abdominal pain at the start, or if they had build-up of ascites, that's the fluid in the abdomen, that the patient, certainly by the second or the third cycle of chemo, should be reporting to us that actually they do feel much better in themselves. So CA125 can be helpful, but we also look at clinical symptoms with the patient as well. And then when we get on to the follow-up, once they've completed their treatment, or if they're on a PARP as a maintenance, we do monitor the CA125, but we would ask the patient as well, because some patients actually don't want to have their CA125 monitored. And that's because they find the anxiety of waiting for the result, when the build up for that result and what that result is. But I must say the majority do want to know what their CA125 is doing. But again, for us as the specialist nurses, it's the education around the CA125. And if once they've finished treatment and it's normalised, as in below 35, sometimes it might be a little bit higher. It depends on what their new norm is going to be. And then it's monitoring the expectations of our patients, that if they have a result back and say it's gone from 35 to 36, or if it's gone from 9 to 11, it's what that actually means, so that they don't become fixated on a number. Because Emma and I will always say to patients, you know, we're treating you, not your CA125. So it can be helpful, but it's not the be all and end all. I can see Aarti's got a hand up.
Thanks, Sarah. Aarti, do you have something to add to that?
Just that I completely agree with what Sarah said, but, you know, CA125 is not going to, certainly even pre-diagnosis, it's not going to be, you know, up and raised for every woman who does actually have ovarian cancer. And equally, you know, it may not have been proven as an effective screening tool for screening, but it's not to say that if a woman is symptomatic, CA125 should not be done because they're premenopausal. If there is symptoms, then CA125 is recommended, and that's in the ovarian cancer guidelines as well. That's all.
Thanks, Aarti. I've just seen a really interesting comment in the comment box from someone saying, I also found I got very obsessed with CA125 monitoring, and this added to my anxiety, which wasn't. So I agree with Sarah. So thank you for sharing your insights. Lovely. So let's move on now to kind of symptom management and living well. We've had a few questions around that. So somebody's posed a question and said, ovarian cancer has made me feel very bloated and full in my stomach. I've had a lot of tummy pain and toilet problems. Do you have any answers or any suggestions for these problems? So I think Sarah's going to start us off on this one.
Okay, so we were a little bit unsure with regards to the person's obviously posted saying ovarian cancer makes me feel bloated. So if it's because there's a active disease there, it can very often do that. But they weren't clear if it is a sort of a constant bloating and distension caused by abdominal ascites, or because we all get bloating during the day, you know, depending what we eat and drink. But when we wake up in the morning, we shouldn't be bloated. Now, if our abdomen is distended and bloated at that point, then that could very well be disease related. So I would certainly hope that with treatment, that either through drainage of the ascites or with the chemotherapy working, that obviously that bloating and distension would then get much better. They also said very full in the stomach, so early satiety, we would say, you know, if they start to have a meal and then they feel full after only a few mouthfuls. Well, again, if there is abdominal distension caused by ascites, the ascites then pushes up onto the stomach. It becomes, you know, quite squished, for want of a better word. So not able to kind of expand as it would normally. So they would feel full more quickly. But again, either with chemo or with drainage of the ascites, you would hope that those symptoms, and those symptoms would be the ones that we would be monitoring as well as the marker, to kind of make sure that the patient is responding to the treatment. And they also asked about, let me just see on the screen, I think it was piles and toilet problems. Now, CA125, sorry, ovarian cancer, we know that ladies are more at risk of having problems with the bowel becoming blocked. So we do like to try and keep their bowels regular. You know, that's something that we, as specialist nurses, talk about bowels and laxatives on a regular basis, especially if they're on treatment, because our antiemetics, our anti-sickness drugs, one in particular, can cause some constipation. So we would certainly at all costs want to try and avoid our patients getting constipated or the bowel going into any sort of subacute obstruction. So we do try and educate along those lines. Piles, well, that's painful and miserable, and we would certainly be giving some ointments to use for that, but also trying to make sure they had appropriate stool softeners just so that they weren't straining. So that's kind of my advice on that. Oh, there was one getting a lot of tummy pain. Well, the tummy pain, I'd be wanting to find out a little bit more. Is it disease related? Is it because of tumour? Or is it because the bowel's becoming sluggish and they're getting constipated? So we're just trying to find out a little bit more about that tummy pain and then trying to treat it appropriately.
Thanks, Sarah. Would it be helpful to explain very quickly what the ascites is and how it starts to build up, what causes it?
Well, I explain it to ladies that the cancer cells irritate the peritoneal lining, and as a result of that, it produces more acidic fluid, more than what the body would be able to absorb. So, and often ladies will describe themselves, you know, well, initially I thought I was just putting on a little bit of weight, you know, maybe time of year, especially Christmas. I had lots of ladies saying, oh, I thought I was, you know, getting a little bit more weight on my tummy, but then it started to distend more and more, and it looks as if I'm pregnant. And that's how some of our ladies would present. So that acidic fluid we can obviously drain off, but it will reaccumulate if we're then not treating it. So the role of the chemotherapy is to obviously try and help control that. And that's also a good indicator if we've drained them just before the start of their chemo. Sometimes they may need 1 or 2 drainage sessions as we're going along, but then when we're finding the ascites isn't building up as much as it was previously, that's a good indicator that the chemotherapy is helping to work on the cancer.
Lovely, thank you, Sarah. So the next question we have is around diet and nutrition. So we've had a question that is, what nutritional advice can you provide? For example, what's the evidence behind the importance of no additional sugar? And Emma, I think you were going to take this one on.
We obviously get asked these sorts of questions quite a lot in clinic, because it's something that people can do for themselves and help themselves feel in control a little bit as well. There isn't any evidence at all for any sort of diets, and unfortunately people can pay an absolute fortune for specialist advice in terms of different diets. And we used to have some ladies used to go to a centre not that far away and pay thousands and thousands of pounds to get these special diets, which involved, from what we could see, lots of beetroot juice and lots of carrot juice, and but there's absolutely no evidence for any of it. We recommend a good, balanced, healthy diet. If people are deficient in anything and can't get their nutritional requirements, we obviously work very, very closely with dietitians, particularly if people have got problems with their bowel and absorption, and there's different things that can be done thereby. People can take a simple vitamin, but if they take any other supplements aside from that, we always ask if they could just let us know, because any over-the-drug you know, supplements can interact with chemotherapy or any drugs, so we do always like to know. So basically our advice is just a generally healthy, good balanced diet, and we don't recommend spending thousands of pounds on any of these other things which really haven't got any evidence base to them at all. Lovely,
thank you, Emma. So we're due to finish at 2, so I'm going to ask 2 more questions before we finish up. So somebody's asked us, is there a support group for relatives, and what other support is out there? So I think, Sarah, you were going to speak a little about what's available locally.
Well, certainly for us, you know, within Cardiff and the locality, there is a support group for relatives at our local Maggie's Centre. They've got a friend and family group that meet monthly. Also, Target Ovarian have on their support line, do have a line for patients' relatives, which again be really, really helpful. What else did I find out? Another sort of well-known ovarian cancer charity do Overcome. They have a phone a friend support line that friends and relatives can also access as well. So, you know, there does seem to be several points of support for friends and family, because that's just as important, really, that they have support as well as the individual going through the treatment.
Lovely, thank you, Sarah. And our final question now. So this is about genetic research and genetic testing. So somebody's asked us, as the daughter of a woman who recently passed away from ovarian cancer, and someone who has been diagnosed with stage 3 cancer, I'm interested to know what genetic research is being undertaken for the screening of female relatives of ovarian cancer sufferers. So I think Aarti was going to take that one on.
So I think there is specifically what we are testing for is the BRCA mutation. So someone who gets tested, any woman who's had ovarian cancer, in Wales now we are testing for the BRCA mutation in both in the tissues that have been removed and in general testing to know whether there is a mutation in the woman. And if there is a BRCA mutation, 1 or 2, then obviously testing would be offered to the relatives of the woman who's tested positive for these mutations. And my understanding is that we've got something known as HRD testing, which is also coming up, which is also a form of genetic testing, which will help direct treatment for the women affected with ovarian cancer. But in general terms for relatives, you know, it is at the moment just testing the women who are diagnosed with ovarian cancer. If they are positive for a BRCA mutation, then the relatives will be offered testing as well.
Great, thank you very much. So as we wrap this session up, I was just hoping our experts could each share with us one thing that they'd like us to take away from the session with us. So let's start with Aarti.
So I think the main thing to take away is that there is lots happening in this field, and there has been a lot of progress that's been made over the years. Emma had alluded to that in the beginning of the talk. And over the years as well, if you see, you know, there have been lots of advances in ovarian cancer. We are not there yet, but hopefully we will get there soon. I think that's my message.
Thank you. Emma, can we take you next?
Sorry, somebody's just put a comment about Lynch syndrome in the sidebar as well, which is very interesting. We're finally now, after quite a lot of years of fighting really, we're now testing everybody with endometrial cancer for Lynch syndrome for specific markers that are diagnostic for Lynch syndrome or indicative of Lynch syndrome. So things are moving forward, not just on a genetic level, but in terms of treatments as well. And they really are changing at quite a dramatic rate. So as Aarti says, there are more and more treatments on the horizon, and things have improved dramatically over the last few years and are continuing to do so. There is still more work to be done, particularly on the early diagnosis and screening, and that's a really big area that we need to. It was very, very disappointing that UK CTOPS was negative, and it's, you know, but that is an area that we really do need to work on. But things are improving dramatically.
Thank you, Emma. And finally, over to Sarah.
I think I would just like to echo both what Aarti and Emma said. It's exciting times now, with lots of new treatments and, more importantly, new tests becoming available, especially, you know, the genetic tests, which has been really helpful, but also having forums like Target Ovarian and putting on days like today, so that, you know, we can try and share our experience and knowledge with ladies, you know, because it's really important that they have forums and platforms that they can gain as much information as possible. And it's great to see when we meet new patients, if they've already been on your website and they come in and they're well informed, or they come in and they've got their list of questions and they're asking, oh, I've heard about this new treatment. I think it's called a PARP. What PARP, you know, what is that? And that's good, you know, because I've been in this role so long, there wasn't all that information out there, and it wasn't readily available. So I just think it's exciting times. We've still got a long way to go, certainly as Emma and Aarti have said, but, you know, I think it's positive going forward.
Thank you so much, Sarah. So thank you so much to all three of our experts for joining us today. We're going to finish now, but we hope everybody enjoyed it and found it helpful. If you have any questions or concerns, or we didn't manage to get to your question, or if you'd just like to have a chat, as I mentioned, our support line's available. So the number for that is 0207 923 5475, or you can find the details. You can also email us, so you can email us and you can find the details on our website. So I'm going to hand back to Soraya now, who's going to tell us what's next.